delighted to be able to have a special, an extra special, I should say, evidence hearing today of the all-party group on coronavirus. Today on the day where the aftermath of the government's latest roadmap out of the latest lockdown is being scrutinised. We are hoping to learn a lot from professionals who understand what went right in Australia and New Zealand, and indeed elsewhere in the world. So to help us do that today, I'd like to introduce an illustrious panel, and I don't think that's an understatement at all. We've got with us a good friend to the all-party group, Professor Martin McKee. Welcome again, Martin. Professor of European Public Health at the London School of Hygiene and Tropical Medicine. We also have with us Professor Michael Baker, Professor of Public Health and Epidemiologist within the University of Otago. Baker is a member of the New Zealand Food Safety Authority's Academy and the New Zealand Ministry of Health Pandemic Influenza Technical Advisory Group. Welcome, Michael. Another Michael, you do not need to be called Michael to give us evidence today, but we have another Michael, Professor Michael Moore, Adjunct Professor at the University of Canberra, Visiting Professor at the University of Technology in Sydney, is the former CEO of the Public Health Association of Australia. So welcome, Professor Moore. And finally, and certainly not least, is Professor Catherine Bennett, founding chair and president of the Council of Academic Public Health Institutions Australia. Catherine is a leading researcher and teacher in public health with a specific interest in infectious disease epidemiology and community transmission. Well, thank you all for joining us. Just to give us a sense of where you are and what time is it. So Martin, you're not far away and in our time zone. But Professor Baker, where are you and what time is it there? Oh, you're on mute.
It's 10 p.m. in Wellington.
It's 10 p.m. Well, thank you so much for staying up late to be with us. Professor Moore, where are you and what time is it?
It's just 8 p.m. and I'm in Canberra, the heart of our nation.
Thank you so much. And Professor Bennett?
Same 8 p.m. I'm in Melbourne, the heart of lockdown in Australia.
Yeah, yes, of course. We'll have no doubt that will come up. Well, thank you all for joining us. My first question is, what we all want to know in this country, what has been the special sauce over there that we can learn from here? So what in your view are the main drivers of success in suppressing the virus? And perhaps I'll start with Professor Bennett, given that you're right in the middle of an intervention at the moment. But we'll go around the whole panel for your reflections. What's gone right where you are?
Yes, we've actually come out of a short circuit breaker lockdown. I think what happened Australia-wide was that early action and decisive action when it came to the first lockdown in the first wave. The second wave is actually a different story for us, and if we've got time later, I've just got some slides that capture some of that. But it had a different dynamic. We had widespread community transmission, but we're also measuring it. But most importantly, we had the virus get into workplaces, significant workplaces, and then aged care, and that all happened very quickly. It changed the dynamic. And so the interventions we put in place the first time, which were very strict lockdown, similar to what you have put in place in the UK, though it was pre-masks. We weren't doing masks for the first wave, but we had more strict lockdown in many respects. And that, where it worked for the first wave, didn't seem to hold the second wave, and we introduced masks. That probably did not only flatten the curve, but bring our numbers down. And but before that really had a chance to have a full effect, we went into an even more strict lockdown. So we actually had a change in dynamic in our second wave in every respect. It was a different epidemiological dynamic. It was a different community participation dynamic. And what I think we had found in the first wave Australia-wide was good community buy-in, even though I think Michael would agree we didn't quite have our public health messaging coordinated across states and with Commonwealth and and there was confusion, as there always is in a pandemic, we did get good public buy-in. But the second wave played out a bit differently, and there's some lessons to learn from that, as well as, you know, we still managed to struggle through. And it was much more split into some fear messaging. So people reacted to that, and we did have people who sort of knuckled down and really stuck with lockdown, but to the point where it was difficult for some people to come out of lockdown in Victoria. And that, of course, was a very long lockdown. So what was success was getting back to zero community transmission, though arguably taking 112 days to get there in strict lockdown perhaps wasn't what we would call success, and there's a lot in there that we need to unpack and learn from. But we did look at elements of that towards the end, particularly schools, which I had mentioned as one of the areas of interest, was something we were able to look at our data and learn from what was happening locally. But yeah, it's been quite interesting to pull apart the pandemic in Victoria, this second wave, and look at where it actually moved through the community. And if you take out aged care and healthcare, that explained, for the second half of the second wave, it explained 2/3 of cases. They're either the workers themselves or their household contacts. So I guess that's an important question when we're thinking about not just the interventions you put in place, but also the rules you have around stepping away from lockdown, and how that looks, how you communicate it, and the public health messaging around that as well. But I do think we had good buy-in. We did have trust in government, and we had weather on our side probably too, as we were coming out of it, as we were, you know, heading into our spring. So that no doubt helped a bit as well.
Thank you very much. Professor Moore, do you want to add from the Australian perspective before we move to New Zealand?
Yeah, I do. And I'm going to add also a political perspective for you, because I am formerly a health minister in the Australian Capital Territory, as well as having a master's in public health and a PhD and things. So the really interesting part to me was that, in marked contrast to previous pandemics, we saw, after a hiccup and a start, a really interesting coordination. I should say I was an independent member, by the way, Australia's first independent minister. So I'm not particularly partisan in my comments at all. And in fact, different governments right across Australia worked together extraordinarily well to achieve the results. And it actually took me, I have to say, really by surprise, because they decided that, first of all, they would all follow the health advice of their chief medical officers. And that is one of the things that really built trust in government. And Australia has seen trust in government really diving very, very considerably over the last 15 years. And we've just seen this curve go right up. And I think we're working on the evidence, we're working on the advice of our chief medical officer. So the Commonwealth is the chief medical officer, the states have the chief health officers, and either the premiers or the chief ministers or the prime minister would almost always stand next to their chief medical officer. And I think that helped build trust, and that coordination they did between them also helped. So the Prime Minister established what he called the Australian Cabinet, and it was a sort of I think there was almost a compensation happening from our previous pandemics, that hadn't really got underway. But when we look at swine flu and SARS and so on, the Public Health Association of Australia had been pushing very strongly for a Centre for Disease Control because of the conflict that happens between the different levels of government. And governments had been resisting that. They would come, and chief medical officers, the Secretary of the Department of Health, would speak at our conferences and go, we don't need it because now we're doing this and this and this. And so they'd actually built up their coordinating capacity, not perfectly by any means. I suppose, Catherine, I might say 80% if I was going to pick a figure out of the blue. But we did see a much better coordination. So the really important messages: much better coordination, much more respect for the science and the health and medical advice that was coming with the politics. By the way, for people interested in politics, I know none of you probably are, but the jurisdictions of different colours that were firm, that went for the lockdown, that did this process, everyone that's been to an election have been returned quite comfortably, and particularly when it looked previously like they would not be returned. And so standing there, evidence-based health has actually been a significant political advantage.
It's really very interesting. Thank you. Professor Baker.
Yeah, look, I think many of the success factors described for Australia are very similar to New Zealand. I think informed scientific input right at the beginning with a very clear strategy. I mean, we actually did give this strategy a label of elimination right at the beginning, and the goal of zero tolerance of cases in the community. And we were just following the successful models of China. And I remember looking at the success in Wuhan and the joint mission report at the end of February. It laid out the success that had been achieved there. And obviously there was uncertainties about the quality of some of the information. And I became a major advocate for the elimination approach. I just assumed the entire world would do this because this was a WHO report that they had actually actively developed with their own staff. And anyone who knows basic infectious disease epidemiology knows you've got a fork on the road. You either control things or you eliminate them. And obviously it's not quite as simple as that, but it's a very stark choice. And it seemed that elimination or containment, I mean, the Chinese didn't give this a name, and I've talked to them about this, that translates, but it just seemed like the obvious approach. So I think the science input, the next central element is obviously good political leadership that listens to scientists and then makes a decisive choice that I think is prioritizing public health. And of course, as the year has gone on, it's become very clear that protecting public health also protects economies. So you're not having to make a choice. So that's one of the great lessons, I think, from a year of data. The other elements are you obviously need to have public engagement and trust. And a fourth element is enough public health infrastructure to deliver what you need to do. And all high-income countries have that, enough infrastructure. You are just using the same basic tools that are available across the globe. I mean, these are the non-pharmaceutical interventions or public health interventions, and that is just managing borders, being able to dampen down transmission with movement controls and so on. I mean, circuit breakers or stay-at-home orders, and then obviously mass masking use. And thirdly, testing and contact tracing, that infrastructure. And it helps, of course, if you are an island state, as the UK is, as New Zealand is. But you have the staggering success of places like Vietnam that don't have those natural advantages. So it's not essential. You just have to have the will to pursue those interventions. And the last essential element is you obviously need a safety net to support groups who are disproportionately affected by those interventions. So I think those 5 elements are really what is required, and they are available to all high-income countries. And I think the timing is obviously important, making that decision early on based on the evidence, and then committing to that. And it's actually much easier, I think, if you have a decisive target. And I mean, there's nothing more definitive than saying we will have no cases in the community, because actually saying we're going to have suppression, or I mean, mitigation obviously was the flu model, which most countries across the Western world happily rolled out without question, seemingly, but then reverted, to a suppression approach. But actually, it is problematic because having residual cases in the community obviously creates a starting point for further outbreaks and then epidemic spread. So I think we found the goal of having no cases has been very helpful. And we still find it a bit, or people arriving in New Zealand find it a bit astounding that the entire country cares about a single case in a border worker just relative to what's happening in the rest of the world. But that's the focus you have to have. And one of the effects is New Zealand's had less time under lockdown than virtually every country in the OECD, just by having this huge focus on stamping out cases when they occur and being very decisive.
Thank you. That's very helpful. And I don't think I had quite appreciated that last point, because in this country, the narrative is that by driving down, shooting for an elimination strategy means more lockdown. But actually in New Zealand, it's been the opposite. So I think that that's really important. Martin, if I could ask you to perhaps answer the question of what have they done right, but also invite you to consider the points that the Prime Minister made yesterday in his speech, where he basically said that going after such an elimination strategy, which he characterizes the zero COVID strategy, that wouldn't work in this country. And there are those who are saying that we can't compare what Australia and New Zealand have done to the UK. Is that a fair comment? Can we not compare, or could we have done it?
I'm always puzzled by this, because it's not just Australia, New Zealand and Taiwan, which are islands, albeit in Australia's case a very big island, but it's also, as Michael said, Vietnam, and there are other parts of the world that have been very successful, even if they do have challenges like Uruguay or Rwanda or Finland or Norway. So there are plenty of places that are trying to do this. And it's this sort of strange, well, they're different in some way, which I find quite puzzling, particularly for New Zealand, a country I know reasonably well, which has an awful lot of historical connections and in many ways culturally is very similar. In fact, so quite why people will respond differently there from here, I don't know. I mean, every time I go there, I'm always meeting people who were at university with me in Northern Ireland and so on. So there's an awful lot of similarities. But yeah, the Prime Minister's approach, I suppose I would turn it around a little bit and say, I can understand how you can drive cases down and keep them down at a very low level. You need to have all the measures in place with lockdowns to get them down, and then have a really good testing and tracing and isolating and support system in place. That's fine. What I cannot work out with a disease which spreads exponentially, in other words, if it's not absolutely level, it's either going up, and if it goes up, it will go up rapidly, and after a while it will get to very high levels, or it will be going down. The idea that you can sort of somehow calibrate your policy responses to keep it at a level which is other than zero, particularly when you're trying to respond to data which are at the minimum about 10 days out of date with when people got infected. So you're picking them up 7 to 10 days after they got infected. Then you're having to analyze them and synthesize the data. Then you're having to decide what to do, and then you're having to do it. So you're always 2 or 3 weeks behind the curve. And to calibrate perfectly this level of infections at 1,000, 10,000, whatever cases, and just keep it absolutely right without it either going up or, as I would argue, we want to get it down. I just don't know how you do that. And I think people need certainty. At the minute, we have a situation where we're yo-yoing up and down, we have been, and that means that nobody can plan holidays, nobody can plan weddings, nobody can plan anything. And that's the real issue. We're always told that markets hate uncertainty. And we're just creating a massive dose of uncertainty by doing anything other than trying to drive it down. Now, of course, I recognize that there are major challenges, particularly when you're a trading nation with a short sea route and so on. But of course, that situation is changing too, but we'll leave that for 1 minute. But I just don't get it. I don't get what the alternative is. And that's my problem.
No, thank you very much. That's very helpful. So to dive into all of these issues much further, we've got our parliamentarians with us who've got a plethora of questions. And start with Lord Strasburger.
Good morning and good evening to our panel. I think we'd all join in congratulating Australia and New Zealand for their success in suppressing the virus and saving lives. And of course, here in the UK, as we've been discussing, our outcome has been the polar opposite, and we've got the highest death rate in the world. I'd like to ask you 2 questions about that. Why do you think the UK's outcome has been so inferior to Australia and New Zealand? And And are there any reasons why the UK could not have replicated what you've managed to achieve in Australia and New Zealand? Shall we start with Professor Bennett, please?
Thank you, Lord Strasberger. Great questions. I think in the first instance, when we looked at what happened around the world, it was the UK going late and perhaps Sweden going softer that made a difference to the way the first wave played out. But right across the Northern Hemisphere, I think it was the fact, as has already been touched on, that there were always those low levels of community transmission, but 300 or 400 cases a day in France right through summer, and not that different across other settings. And that was what you were detecting, not necessarily what was actually out there. And so you had the potential for multiple seeding events. We use bushfire analogies here in Australia, and we talk about smouldering logs, and you just had thousands of them potentially out there to take off as soon as your winter months started to bring people indoors and so on. So in Australia and New Zealand, I think that whole point about suppressing here or eliminating in New Zealand was the idea was you would, as you say, equilibrium would take you down to zero if you had that aggressive strategy, so that you would find a new spot fire and you would try and contain it. We discovered how difficult that could be in Victoria. It had got away from us, and it was like a microcosm of what you're experiencing in the north in trying to actually manage multiple fires at the same time and make epidemiological sense of what was going on and know what strategies to put in place. So could other countries do what Australia has done? Yes, but when the lockdown talk happened over the last few months, it was always still at a level where people in Australia would comment on the UK and just say, but the pubs are still open, or they're closing them earlier. Whereas we had decided to go all out when we did close down. I do think that we could have learnt more from what we did in Australia and New Zealand about what really matters, so that we pare back and we know exactly which bits of lockdown are the bits we should focus on, particularly now we're using them as safety nets for small outbreaks, for example. And that might have been something we could have shared, and it would have helped put the focus on those areas where I think you're most vulnerable to those chains of transmission still occurring at a sufficient rate that it undermines what you're trying to achieve. And then you get into that oscillating cases, but also that sort of public buy-in and cynicism that can happen around lockdowns not really working, or lockdowns not actually, really stopping some of the very activity that people are worried about.
You mentioned our lateness, and also you implied that we weren't thorough enough in our lockdowns. Does that, in your mind, mean that we missed the boat? By the time the prevalence was that high, as it became, by the time we had the first lockdown, was it too late to go for this zero tolerance of community transmission, or could we have got it back together, or could we still get it back together?
Look, I maintain that if you go into lockdown, it actually doesn't matter whether you've got the virus in 0.01% of the households in your country or 25% of the households. The whole point of locking down is the virus dies out within households. And so you can have widespread transmission, but it means you have to have widespread and very strict lockdowns, and you have to have them in place long enough to work. We didn't measure our community transmission in the first wave. We weren't testing people even if they had symptoms outside of our return travellers and known linked cases. But we successfully shut down and eliminated the virus in the first wave. In Victoria, we've got the genomic test to show that. And so without even knowing how far spread it was, if you look at the data for our second wave, again, it's probably 6 to 8 weeks, but that's where you see the shutdown happen in community transmission. It was the reseeding into the community through workplaces and these long outbreaks that happened, particularly in aged care, that kept things going. So you've always got that balance with your essential workers and those things you need to keep open. But if you can keep the virus out of your healthcare, your aged care, your distribution centres and so on, then you do have a chance, no matter how widespread the virus is in the community. If you can cover that with a sufficient lockdown for long enough to actually close down community transmission, if you're also snuffing out those seeding outbreaks, which are bringing the virus in, or you close your borders, so you're also not seeding from outside.
Thank you. Professor Moore, please.
Catherine, of course, was in Victoria, and where the most difficult challenges were for that second wave. And the rest of Australia basically had a series of shorter but also strident lockdowns. They've actually really built on the learnings from Victoria, I have to say. I think it is worth going back to the very beginning, though. The goal at the very beginning was not elimination. At the very beginning, the rhetoric, at least politically, was to protect our hospital systems, our intensive care units, and so on. And I think the early success then may have been part of why we went, actually, maybe, as I perceive it, maybe we can achieve a zero result in terms of the spread of the virus, 0 cases. Whereas I think New Zealand, and Michael will elaborate on this, but I think New Zealand actually went straight away for the zero community transmission. So I think there was a difference in there, and Michael's 5 elements, I think, are really, though, the key elements in answering your question. And when you look back at the UK response, I think it was basically weak on almost all of them. And whereas our contact tracing, it improved. It wasn't perfect, but it was certainly seemed to be better than what happened in the UK, along with these other tactics or techniques, if you like, or the 5 elements that Michael was using. And look, I concur with Catherine. I think all of us have people we know very well. My niece has just had a baby in Birmingham. We know people very well in the UK, and it has been challenging for us and frustrating for us to watch and go, why doesn't the government just? And I suppose I could leave it there. In some ways, it's an easy thing for an outsider always to say, but in some ways, it's been quite frustrating. I hope that's helpful.
Thank you. Professor Baker.
Yes, well, look, I absolutely concur with the previous speakers. It's hard, as others have said, as an outsider, to comment on what happened in the UK, but at a distance and through conversations with people like Martin and also Neil Pearce and other epidemiologists I know in London and the UK and Scotland and Ireland, it did seem that a key factor was how the problem was conceptualized early on. And a lot of people talked about how this was perceived to be like influenza. And I think even sort of thinking about herd immunity for a period. And of course, if you look at an influenza wave, it comes through, it's very abrupt. In New Zealand in 1918, the influenza came through in 6 weeks and killed 9,000 people, 1% of the population in 6 weeks. And then it was gone. I mean, it was brutal, but I think many people thought that COVID-19 would behave just like influenza. So you had a herd immunity. And I know it was sort of talked about in the UK and the Netherlands and Sweden, and possibly only Sweden really stuck with that as really almost the official strategy for a while. But I think there were shades of that thinking persisted, maybe even till, well, possibly not till now, but for a long time. And I think that did affect, there wasn't the scientific unanimity about pursuing more of the SARS model, which was very much that you had chains of transmission and you would stamp them out. And that was the way to interrupt the disease. And of course, in New Zealand, we realized we did not have anything like the testing and the tracing capability early on. So we were back to the basic, very medieval approach of just shutting the country down and saying to everyone, stay at home. And for 7 weeks, everyone did that, partly because they were so terrified looking at images coming from northern Italy. And basically, that extinguished chains of transmission. I mean, it's the crudest possible way, whereas testing and contact tracing, of course, just does exactly the same thing, but it does it in a surgical way. It's very precise. You identify the cases and you quarantine and isolate. But if you don't have those resources, you know that the circuit breaker or the lockdown or the stay-at-home order just achieves the same thing, but just at a very crude population level. It will stop anything or any respiratory virus, probably.
So you seem to be saying that we didn't take it seriously enough, early enough. That would seem to be a summary of what you said. And
it was perceived, I think perhaps that it was conceived as a different. I mean, you had the whole Western world had spent 20 years rehearsing the influenza pandemic plans and dutifully rolled them out. And New Zealand was going to do the same until really last minute interventions by a few of us to say, actually, we should follow the Chinese model because it actually seems to have worked. And we had, enlightened politicians, and New Zealand is a bit of a village, so you can just talk to the politicians directly, and they listened.
Right, thank you. And Professor McKee.
Well, I'd concur with everything that's been said, so I won't repeat it, but I think one additional factor that we didn't fully appreciate here, which was the extent to which areas with high levels of deprivation were going to be breeding grounds for the infection, and particularly with multi-generational households and with people with an informal economy, the gig economy, so that people were unable to isolate, where there were powerful incentives not to get tested, not to take time off work and so on. And I think that in the first wave, while the level of infection came down in the country as a whole, it never really got suppressed up in the Northwest, in particular Blackburn, places like that. And that was where it sort of spread out from again. And I think it's very worrying at the minute as we're seeing a big gap in the uptake of vaccination, even within some of the northern cities. So I think we need to be cautious to not make the same mistakes and to not focus on the aggregate numbers, but also to look at the distribution on all of these things. But otherwise, I agree completely with what's been said. So
I note that none of you has picked up my second question, which is why couldn't we have done the same and had the same results in the UK? Is that a fair comment? I'll give you a second chance to volunteer something in that area. Is there
Martin,
any
do you want to have a crack and then we'll move on to
Yeah, I think we could have done the same, actually. And I think this point about not having the right plan, which I've said before, I've used this analogy of a ship in a storm, and you need to have a captain at the bridge who's paying attention, but they also need to have the right chart. And we had a chart that was marked pandemic influenza, whereas other countries had a chart that was marked SARS. And that made a huge difference. And of course, some of the other countries, not so much Australia, New Zealand, but the ones in Southeast Asia, have had since 2003 to prepare for that, which of course helped a great deal. That's more in Taiwan and Singapore. So I think it was entirely possible. And, in the end of the day, there's now a growing literature on the political determinants, to go back to Michael Moore's point, on the way that politics played out in all of this. I won't rehearse it again, but I think you saw very clear political leadership. You saw very clear messaging with Jacinta Ardern and Ashley Bloomfeld, the chief medical officer there, working very closely together. I think also in the states and territories, and very much at that more local level as well as the federal government. And also, I think a big advantage there was that, as you said to Michael Moore, everybody was working together. And that's so different. I mean, we had a bit of an issue here, but of course it was much worse in Italy and Spain in particular, where there were huge problems. But I think that cohesiveness is really important. Politics really does matter.
Thank you. Back to you, Chair.
Barbara Keeley.
Thanks, Chair. I want to come on to talking about exit strategy. What do you see as being the key tests or pillars that must be met or be in place before lockdown can be lifted? If we start with Professor Bennett, I think you were indicating then anyway.
Thank you. I have a fascination with exit strategies. I think it was a struggle for us in Victoria. The first wave was quite clear cut. Our state went later than others, to be sure, you know, to be extra safe. But most pulled out, eased out, and we could see there was a legacy, you know, in terms of people keeping their distance and so on, even after we eased out of lockdown. But the second lockdown was very different for us. And I just wanted to touch briefly on a point relating to Lord Strasburger's question and Martin's response around where the virus lands. And the second wave for us, it landed in casual workers, it landed in lower socioeconomic belts, it landed amongst migrant workers, and it landed in public housing towers. And so that's where things changed very dramatically. But we introduced, it took a little while, but we did get things in place that were hardship payments. So if people had to go into quarantine, it meant, you know, if they couldn't go into work, they had some money in pocket. Not means tested, it was just handed out, no cost in administration. It was really designed to try and support people and make it happen quickly. I guess the challenge with that, though, is, of course, if you're a casual worker, it doesn't mean the work will be there next week when you do go back, even if you've had money to tide you over. So there are a lot of issues around that. We as epidemiologists, when we looked across, you know, the problem that we had in Victoria and we're coming out, I think every epidemiologist said, it's about getting your numbers down. You know, the public wanted to know, everyone was dying to get out of this lockdown. So we all talked about getting into double digits. But what was most important were what was called mystery cases here in Victoria. And that was a signal that you actually weren't on top of the outbreak. You didn't know how all cases were linked. You had people not coming in for testing, or you had silent transmission in asymptomatic people in the community, or your contact tracing wasn't just connecting all the dots and that wasn't up to speed. So in fact, mystery cases were an indication of the health of the public health response in a way. So it was those two things that we used to evaluate readiness to come out of lockdown. We had a roadmap in Victoria. It was informed by some modelling, but it was interesting because the modelling used actually wasn't modelling the exact precautions we had in place. And it didn't actually model the mapped roadmap to come out of lockdown either. So it was a strange use of modelling. I actually think it's one of those areas where we could have done a lot more in terms of the data and science informing policy and taken the public with us if we'd been much clearer on that. The one exception where I think modelling was particularly useful from a public health perspective was in schools. And that work actually changed policy. They changed the roadmap to open up schools a bit earlier for younger children when they realised from the modelling, they were confident and they had good data behind that, that wasn't going to pose an unacceptable risk given where we were in terms of the epidemic. So I do think it was about formulating a roadmap, but taking people with you in terms of the evidence behind the roadmap. But then I think it's about sticking to the roadmap. So there were a lot of people that thought the roadmap, myself included, was particularly harsh. You had to get to 28 days with 0 cases on a 14-day rolling average, which meant, you know, a long time with no cases, to actually open up to a level that other states were managing, even if they were managing local outbreaks with contact tracing and so on. But in fact, we didn't actually even stick with that. So they introduced additional rules. We had a rule about not moving more than 5 kilometres from home. Then they would carry that forward into the next step. They shifted dates. And so I do think if you have a path and you are basing it on evidence, you should stick to it, because otherwise, you know, you don't have people then knowing what not a reward is, but what is now safe, or what you said was safe, should be safe if it's been well thought through and laid out. So I do think there were a couple of issues with the way we stepped out. By the time we came out of lockdown, we had no cases in the community. And I'm not convinced that you have to stay in lockdown till you have 28 days of 0 cases, because, you know, you as we've all said, you've got that 10-day lag time to see what's happening. If you're monitoring it really closely, you have early warning systems in place and you can mop up outbreaks, then our data show that the last 6 weeks were really quite contained outbreaks that could have been managed without the rest of the population in lockdown. So it's actually when you bring the lockdown in, and we introduced not only contact tracing, but also going to secondary contacts at the same time. That's about, that you can only do that when your case numbers come down, but that does bring lockdown to the actual areas of exposure and gives you more freedom to open up. It took us a long time to get that in place. We had it in place for weeks before we opened up, but that's was seen by the Premier in particular, who's by this stage very, very cautious, to actually be the key to coming out of lockdown, was knowing that you had contact tracing in place, that extra step in the contact tracing that not only helped contain the outbreaks, but told you when you'd come to the edge of it, when you found that ring of contacts, all who were negative, you knew the virus hadn't gone beyond those close contacts. So that in itself was reassuring. Plus some of the early warning systems like wastewater and so on, which come into their own once your case numbers come down. So it was having those strategies to maintain, but the vigilance then built around that to have the confidence to be able to open up safely. But yeah, getting the balance right, I think, you know, we erred on the side of caution, which cost us dearly financially and I think in terms of public morale.
Thank you. Professor Moore, do you want to add anything to that?
I'll just have a brief addition because it's really Catherine's area of expertise. I think one of the other issues we haven't really touched on was the communications that were going on. You know, the Victorian Premier every day it was, Catherine, correct me, 120 days or something straight was on television answering questions, taking whatever questions, and going through a press conference, quite long press conferences, and saying, no, it's my responsibility, and this is what we're doing. This is the roadmap. As you say, it was adjusted, but this is the roadmap. This is how we're going to get out of it, and this is what we're doing about the economy. So, and I'll come back later to the issues around the economy, but I think that was quite important.
Thank you. Professor Baker, from the New Zealand perspective?
Yeah, well, we've got two different experiences coming out of lockdown. The first one was in the first wave when we really didn't know what we were dealing with and how effective these measures would go. And so we were very conservative, and a bit like what Catherine was saying, we were using a mixture of observational data, very high volume testing, and then at a certain point not seeing any evidence of the virus. And then the modelling was starting to say that the probability of the virus still being circulating was very low, but still there was this real conservatism about coming out of lockdown too soon. And it was, we started right away with a 4-level system. And so we went to the highest level and then we were stepping down that, but very cautiously. I'm sure we could have gone faster. Now we've had one moderate sized outbreak a few months after 3 months of no cases. And we were starting to use the lockdown in a far more targeted way because we had better modelling and more extensive testing and contact tracing. And now we're just having we have the odd border failure and a few cases in the community. And so we're now using the sort of lockdown methods in a very geographically targeted way and not barely going into a stay-at-home order, and combined with very high volume testing and contact tracing, that seems to work very well. And the modelling is, with these very small numbers, is not very precise, and we often are relying on looking at the results of testing contacts and contacts in their contacts, and looking at a certain point when you're not seeing any more cases in the people you're testing. It's quite reassuring that you can relax at that point. So I think it's moving from the blunt instruments to the very targeted instruments as you get more comfortable with using them. And I think the public also understands better the process.
Okay, thank you.
One thing I did have a question, of course, is the other huge change now is that we have vaccines combined with public health measures. So the rules are going to change dramatically in terms of what elimination means, because this is another thing that surprises me is there are numerous elimination strategies rolling out around the globe and have been for several decades. and they generally require vaccines, but they're not vaccines on their own. They're always combined with public health measures as well. So I'm just interested in this, what will be a combined assault on the virus with both of these tools. And all it means is that elimination is that much easier. And it does seem sometimes with the terminology, people think there's vaccination or elimination, but actually they are a combined approach. And so I'm sure with vaccination, we'll have to rewrite the rules or our experience of how it'll be much easier to achieve zero transmission.
Okay, thank you. Do you want anything to add, Professor McKee?
Well, just to add to what has been said, I'm very much involved in a lot of discussions around this in my role advising the European region of WHO. And we're trying to look at what the long-term prospects are. And by that, we're trying to pull together the best expertise on the evolution of the virus, in particular, talking to virologists and mathematicians about whether it will be evolving in what we call convergent evolution towards some perfect fit or very good fit with the receptors. Or will it be like influenza, which we think it probably won't be, where you've got 8 subunits that are constantly mixing and getting in bits from pigs and from birds and so on. And if we do get the convergent evolution, then we will probably need 1 or 2 new re-engineered vaccines, but it won't be an annual one. So that will be good news, but we need to understand that better. We are a bit concerned at the minute about the evidence that the new variants are infectious for longer. And Michael Baker, I'd be interested to talk to you later about this as to whether that's accounting for some of the escapes you're getting in people who are infectious after coming out of quarantine, as to whether that may be something we need to be concerned about. And we also need to know more other very encouraging signs coming out from Scotland, from Israel, about the role of the vaccine in preventing transmission, and also looking at ways in which we can use innovative measures, not innovative, but established measures of surveillance in wastewater, sewage, and so on. So we're trying to pull this together to look at perhaps the longer term, not just getting out of lockdown, but how we actually get to a real long-term control, elimination, whatever. And this is work in progress at the minute because there are so many uncertainties, but there is quite a bit of evidence that we can draw on, which we're doing at the minute.
Thank you. Thanks.
Thank you very much. Just before we quickly move on to Philippa Whitford, the government does seem to be relying, and this is for Martin, just very briefly, relying very heavily on mass testing. So it's mass testing and vaccination that seems to be the main thrust of their approach right now. Can you just quickly comment on what evidence we have that this is going to work?
Yeah, so we published a paper in the British Medical Journal recently. I was working with colleagues, including Ian Buchan in Liverpool, where we looked in some detail at the different strategies, the different ways in which you can use mass testing. In brief, there are advantages of PCR and advantages of mass testing and disadvantages of both. So they're different. The rapid testing does seem to be better at picking up people who are actually infectious. You do get some false positives in people who had been infectious and now no longer are. And essentially, to cut a long story short, what we argued was for a really carefully thought through strategy about when these tests are appropriate and when they can be used. And the big message that comes out of Liverpool is work with the local communities to find the ways in which they can work. So for example, they were using them for daily testing with the fire department, the fire service, because they were having a problem in that once one person was infected, the whole fire crew was unable to function, and that was a real danger. So they have, I think, a lot of very good experience that we can draw on, but you have to work with communities on the front line to find out how they can be used, where they can be used. They have an important role, but it's not as simple as the government is portraying, I think.
Thank you. Philippa Whitford.
Thanks very much, Leila. If I could start with Professor Bennett, and then I'll come to the two Michaels. How concerned are you about new variants, particularly ones that might be more vaccine resistant, like the Brazilian or the South African, or more infectious, like the UK variant? And do you think that means that we really need to maintain tight border control or border quarantine for a long time, possibly throughout this year. I mean, last summer, Scotland managed to eliminate almost all of the 300 strains that we'd had in the first wave. We got right down to elimination levels, and then everyone felt they had a God-given right to go on holiday, and off we went again. So are we stuck for 2021, do you think, with tight border controls?
Well, that's been the big question, you know, because of our border closure strategy being one of our main tools. What I can imagine is we're mainly focused on using AstraZeneca vaccine. So we do have a concern about the variants and a clear and present danger with the variant we associate with South Africa. So I do think it's going to play out on borders. I do think the way these variants behave, including potentially longer infectious periods, is something that's been on our minds a lot of late. We've introduced testing to everyone leaving our hotel quarantine at the end of testing. We only did that if they hadn't tested positive previously as part of their exit strategy. Now, if they do test positive, they are still screened and then reviewed by a panel if they're still shedding virus. And we've introduced day 16 testing. So we keep ours in quarantine for 14 days, even if they had an infection. It used to be 10 days or 3 days after symptoms. So we've tightened all of that up because of this uncertainty about the new variants. We do have to have the big conversations about when and if we let the virus into the country. If we think the vaccines covered us enough to protect our elderly, our vulnerable, our health systems from that impact of serious illness and deaths, then it might be that we are in a position to relax the borders, but not if we still have this clear and present danger that we're watching out for, which are these variants, particularly given the vaccine profile in the country. So I can imagine a scenario where we continue to have quarantine, but maybe it's actually screening for variants. And if you come in and you're positive and it's a garden variant, I know we have got evidence of co-infection, but I think that's very rare, that you might say, okay, you can go through because it's not a variant we're worried about. If you're not positive, then you might have to stay in quarantine till we know whether you're going to become positive. And if you've got the variant, they're the people that we hold in special quarantine to be sure of. So I do think we have to think about that as we're in that process of understanding whether we do need to then move to the next generation of vaccine and what that means for how we manage the virus at our borders and within the country.
What are your thoughts about the fact that in the UK, having finally introduced border quarantine after a year, it's so limited? It's only the 33 red list countries, even though we know the South African variant is in at least 35 other countries. And of course, there could be a new variant none of us know about yet.
Look, I think it's very interesting. We could have the length of the Victorian lockdown spent just discussing contact tracing alone, let alone hotel quarantine. It's a hot issue because, of course, all our virus in the country has been, apart from the initial travellers, failure at our borders to contain it. And I have talked to the BBC about your hotel quarantine as well, and the fact that it is 10 days, the fact that people are allowed out for exercise, a range of things that to us just come back to how I think we perceived lockdowns initially, is that there's too many holes in this sieve. And you know, we keep talking about the Swiss cheese and how you have to have layers and layers. We test our hotel quarantine staff daily in Victoria. It's one of the things I really pushed for when we reset our quarantine in Victoria. That's what we put in place. We now test our hotel quarantine workers daily on their days off. That's being introduced because we had, where it was crossing over from the borders, it was someone who'd gone home, tested negative on their last day and was positive by the time they came back to work, and the exposure had already happened in the community. So we didn't actually look at our hotel quarantine end to end in a sufficient way, as it turned out. We weren't really managing our airline crews very well, particularly the ones who were Australians and were allowed to go home between shifts. So I do think there's a real challenge for us in having meaningful border control. I mean, we were always taught in microbiology, it's your weakest link. And if you're going to let, you have too many holes in the sieve, then why bother with the sieve? And I think that's what you need to look at. It's having a really credible, hard commitment to something to make it work, or pull back and then have your surveillance systems in place, your early warning, your testing, your sentinel worker surveillance, that sort of thing.
Thanks very much. Professor Moore, if I come to you before we look at New Zealand, do you have anything to add?
Well, I was going to say it's great having Catherine here because she covers the areas so methodically, but there is an elephant in the room. We had a very conservative national government who had spent years talking about national debt and bringing national debt down. And they basically immediately turned that completely on its head and said, no, we have an emergency, we are going to spend, and we're going to spend big, and we're going to put the safety nets in place to allow all of these other things to happen. And they did, and they borrowed to do it. It did sort of put a lie to the way they've been campaigning for 15 years. However, I think it actually helped build the trust. And, you know, we've touched on trust quite a number of times because they said, no, this is a serious emergency. In terms of the new variants, I don't have that much to add to Catherine, other than it's really, our community is very, very conscious of it. And we're conscious of the fact that our systems have by and large, and quarantine systems have by and large worked, and we want them to be held very firmly. And so I think that if there's any risk around the variants that is perceived to increase chances of spread, then we'll see things tightening up. And we're all, of course, hoping that the vaccines are going to cover those variances as well. But we've got to see.
Yeah, I mean, we look from here, obviously, in the UK, there is still this battle between public health and economy, and it's almost like a pinball between, we have a surge, we have a lockdown, then we push people back out, then we have another surge. Whereas we look at you, we look at the Australian Tennis Open and see that if you control your borders, you get your domestic economy and society back, whereas we're a bit stuck in the worst of both worlds at the moment. If I can come to yourself, Professor Baker, to finish off, obviously from the New Zealand point of view.
Yeah, I think it's very similar to the Australian perspective. I mean, one of the huge benefits of eliminating transmission is you don't have to worry about variants anymore. And it is a good insurance policy if that's your goal. And also it reduces, obviously, viral evolution, you know, the selective pressure favouring both more infectious variants and variants that escape the vaccine, as if we can get the numbers down to 0 and then obviously deal with the odd outbreak. You've got a lot more, you've got another key tool, which means you're not dependent on vaccine. I mean, obviously vaccine's a key method for getting there and you're still going to do it, but that is one of the other benefits of it. I'd also agree with the points Catherine makes very well, that if you're going to invest in border biosecurity to stop the entry of the virus, you really have to do it properly or not at all. I just don't see the point of sort of dabbling with it. And that's what really, I've done one or two interviews with the UK on the subject, and when they described what they were doing, it was very hard for me not to express real skepticism. And like everything, you have to have a purpose for doing it. And probably repeating myself to say that aiming for no transmission in the community is a very powerful unifying force for pulling all your strategies together, and for also communicating to the public what you're trying to achieve, because people have got right behind that. And I think certainly Australia and New Zealand and other countries, Vietnam, I gather it's such a unifying focus for the whole community to actually have no transmission, and if they have cases, to stamp it out. It's a very relatable goal.
Thanks very much, Professor McKee. Obviously, we have the Kent variant, which is a homegrown domestic one. How much do you think the opportunity for that to evolve came because there wasn't early enough action in the autumn. Obviously, SAGE called for a firebreak lockdown in the UK on the 21st of September, but that lockdown didn't happen for another 6 weeks. Do you think those high levels contributed to developing that variant?
Well, as you well know, viruses that don't replicate don't mutate, so therefore it clearly did. And we look to the example of SARS from 2003 that is no longer circulating. It hasn't mutated, then it's really not surprising. And this is, I think, another strong argument for suppressing the levels, because as long as we continue to let them circulate, then we will just accumulate mutations. The big question, as I mentioned in one of the earlier answers, is whether we're getting this convergent mutation to a perfect fit, and then any further mutations will be a less good fit, and it will have an evolutionary disadvantage. And of course, that could change with vaccination as well. But I think we don't know. There are some interesting papers using in silico modeling, looking at the potential variants that could arise that we're trying to understand. I mean, Catherine may know more about this than I do, but I'm struggling to try to get my head around all of this at the minute. But we as long as if we can suppress it, it's not going to mutate at anything like the same rate.
And do you think the vaccine resistant versions such as South Africa could undermine the vaccine program here, on which we seem to be kind of betting all of our money?
It's really difficult to know. And the other thing is, of course, looking ahead, we already are looking at the potential for inhaled vaccines like we do with children with influenza, which may have a greater role in preventing transmission. So there's a whole lot of things that are quite uncertain, but I would defer to people who have more expertise than me here.
Thanks very much. Back to you, Chair.
Thank you so much. Caroline Lucas.
Thanks, Leila. And you've all mentioned test and trace at least once or twice so far in what you've been telling us. And what I would love to understand better is how critical a functioning test and trace system has been to your outcomes. And in particular, what's been done in New Zealand and Australia to ensure that when cases are traced, that the chains of transmission are actually broken. And you'll know we've probably got some quite big issues here around the amount of support that's been given to people isolating. So I don't know, maybe to change the order, maybe start with Professor Baker, if you could give us your view on that.
Yeah, look, there's great questions. And again, it's like the borders. You just have, if you're going to do it, you have to do it well. There's no point. I mean, it's got all these elements of testing, isolating cases, quarantining contacts. All those elements have to be in place. And quite early on, we realized that when you found someone who was positive, you couldn't rely on them isolating at home. You basically had to put them into one of the managed isolation quarantine hotels that are used for people arriving into the country. And then we realized you had to also put their family members in there as well, because they'd been often heavily exposed. So they then had the same experience as people who are arriving into the country, because essentially your country is split into two groups: those in the country who are virus free and those who've been exposed either through arriving from overseas or through contact with a case and found to be exposed as a result of contact tracing. So you had to apply the same level of rigor to this subpopulation. And that took a little while. I mean, that took a few weeks of experience to realize that. I don't know what you do in the UK, but, and then the other thing is you also look at a huge professionalization is needed of that approach. You need very good information system, trained staff, very tight performance indicators on the speed of identifying contacts. You really need to take a very business-like approach to this. Of course, like most things in New Zealand, we have done this within the state sector rather than contracting it out. And that has resulted, I think, in high quality, a very high quality state-run service throughout. So a lot of learning along the way. Some things we did use contractors, and we found they were not generally up to the task, and it's been pulled back more into the government sector over time.
Wow. I mean, can I just understand that you're saying that anyone who was self-isolating and their families, were they required legally to go into a quarantine hotel, or how did that actually work in terms of enforcing it?
Well, they were strongly encouraged to go, and occasionally some people wouldn't. I mean, some household contacts said, actually, I'm going to stay at home, and they were managed in their homes, and they had the same testing and so on regime. And in many cases, they weren't, of course, infected. But over time, people actually found it was easier to go into these facilities and be cared for because they were quite worried about the risks to family members getting infected. So that became the norm after a while. And I think, actually, I don't have data on how often people rejected it. I think it was very unusual that people rejected that kind offer from the state.
And what kind of financial support was given to them as well? Because one of the problems we have in the UK is that only 3 in 10 people who should be self-isolating are self-isolating because it's so difficult to get financial support. And even if you do get it, it's at a pitiful level.
Initially, there wasn't support. Then that was phased in. So there's a special allowance for people to cover this period of being in quarantine or isolation. And
is it
also,
enough that people get a sense that it's, I don't know how you would compare it, for example,
yes,
to your minimum wage, your living wage, your average wage?
It's a good question. It is a subsistence level. It's probably approaching a minimum wage level. The other thing is that sick leave has also been, is a special entitlement you can get now if you need to stay off work as part of a contact tracing process while you're waiting the results of your testing. So once someone's tested, they have to stay at home until that result is available, and they may be required to stay home longer and be retested if they're a high-risk contact in the community. This isn't household contacts. So it has been a moving process and adding lots of refinements along the way to make it really work.
So those people that were staying at home waiting for their tests would get, again, the equivalent to roughly like a minimum wage type amount. Is that what you mean?
Yeah, they can, yes.
Okay, thank you. Professor Moore, maybe I could come to you next.
Mostly Catherine has much more expertise than I do on this, so I'll be very brief. And she has lived through it. In my jurisdiction, we've had minimal lockdown, actually. And that has been through a series of things to be mentioned before. For me, one of the interesting things was using police to check when people are in self-isolation, and they were both phoning and visiting as well. I often wondered why they weren't using police for the normal contact tracing, because these are skills that police officers actually have. And I would have thought that this was a fairly obvious use in a set of circumstances that we had. I'm interested in Catherine being critical of that comment, but she has much more expertise than I do on this.
Okay, pressure's on. Professor Bennett.
Thanks. Look, we do have some differences to New Zealand, and we have some differences in my state to the rest of Australia. As Michael said, we bore the brunt of it. We had at our peak 725 new cases in a day. When you think about the households that you'd have to manage, we couldn't put them into quarantine if we'd wanted to. They always had an allowance. If someone was vulnerable and not infected and someone in their house became a case, then there was the option to separate the household and try and protect the vulnerable. Also, larger households, of course, you could potentially have them in isolation for a very long time if there was a slow serial transmission from person to person, particularly if they had children, for example. So there were different circumstances where managed isolation was an option, but in the main, the vast majority of our people, and I think we had at our peak, I'm just going to peek at my spreadsheet here for our active number of cases, but we probably peaked at where were we up to? We had something like, 3,500, up to 7,500 active cases at any one time. So they would have to home isolate, and we would have these spot checks. They didn't check on them all the time. Initially, there were reports that 25% of the people weren't where they were meant to be when the police went there, but that was actually a communication issue. And it turned out the percentage of people who failed that random check was incredibly low. It was incredibly low. So people were actually in the main compliant.
Was there a sanction if they were not found to be where they should be?
Yes, our state had moved down the pecuniary path, which I think was unfortunate given that people were so compliant and working so well with government, but very serious fines that got up into the thousands of dollars for breaches of particular kinds in the end, mask wearing, not being in isolation and so on. But people were actually amazingly good. The risk is always that you don't know if they're having people over to their homes or, and other ways that it might not work. But of course, it did work for us. We managed to get to our 0 cases. And so it was clearly sufficient, even if there was the odd breach within that, the majority, it was managed well. Our contact tracing, as Michael alluded to earlier, got better over time, but nowhere more than Victoria. The contact tracing we now realise was, it was a miracle that we actually managed that first wave as we did with lockdown, because it didn't. The downside was it didn't test our contact tracing, and we didn't realise how undercooked our contact tracing system was. So we came out of that first wave not even being aware at the time that we were actually approaching elimination. As the second wave took off, it actually, the seeding of the second wave actually was in the tail of the first wave. And that took off very quickly because, as I said earlier, it got into those very extensive households in very well networked parts of the community and people with multiple jobs. And we found out very quickly the contact tracing wasn't working. And this was perhaps the big area of contrast to what Michael's presented in terms of trusting government and the communication from government. But there was this combination of the concern about how direct the government was being about owning this problem, that this seeding had happened out of a hotel breach, but also about how good the contact tracing was. And so they were talking it up. They were saying, it's fine, it's fine. And yet we were hearing more and more stories from the community about, businesses that waited a month to hear from the government when they'd had an outbreak in their restaurant or something. So there was this disconnect between the government messaging and clearly what was going on. The other disconnect was we didn't build off our outbreak management teams. We actually built something in a big tent over here that sat outside our health department. So we weren't building on that expertise as well as we might. And then we did what you didn't do, Michael, in New Zealand. We outsourced contact tracing, and we also had other states contributing. And we lost some of those precious things that make for a really good contact tracing system, and that is local knowledge, local relationship with community leaders, particularly as we had the second wave in areas where it wasn't just about having someone who could speak the language, but understood what those people in the community understood about government and how they wanted to interact with government, and how they networked. What contact tracing looks like in some of these communities is very different to what someone sitting in an office in another state might envisage.
Can I interrupt you just a second? Because I'm really sorry. I'm just very aware that we're beginning to run out of time, and there's just one more thing I wanted to ask you about the financial support that people got in your state.
So we did have, I think it was about $750 if you had to go and get a test, because you might have to wait for 2 days or so to get your result back. And then we had another payment, which I can't remember now, it's $1,500 or $1,750, which was for all the people that were, needed to isolate.
Did you ever have a problem with people saying that they couldn't afford to self-isolate?
So that was the concern, and that happened in the second wave, when we had this community impacted, and particularly the casual workers who didn't have sick leave. So if you didn't have access to sick leave, this hardship payment was put in place. But as I said, you really only had to ask for it and to, demonstrate where you worked that didn't have sick leave, particularly if you're a casual worker. And so a lot of people did tap into that. But as I said, it wasn't always just the money, though. I think some people's views about their own job security could mean that wasn't necessarily the answer for those people. So I'm sure we had problems with people coming forward for testing, but at the same time, I thought that was a great move, particularly knowing the parts of the community that were impacted at the time.
Thank you. Sorry to rush you.
There are also some financial problems around foreign students who haven't been able to. Yeah.
Yes, who was stuck here and couldn't work, couldn't do anything. Yeah.
And did Professor McKee want to add any last word on that one?
No, I've got nothing to add given the time.
Thank you, and sorry to rush you. It's only because I know that there's
No, thank you. Thank you very much. Yes, indeed. We've got about 15 minutes left. And so my plea to parliamentarians and panelists is keep it short. I'm also very aware that Professor Baker, it's approaching midnight. We are very grateful, and I just wanted to restate that. Baroness Masham.
Oh, it was me.
Oh, sorry, Baroness Brinton.
Sorry.
Apologies.
Thank you very much. My question originally was about deprivation and ethnicity, but I think we've covered deprivation quite a lot already. So my question is, were there specific issues about ethnic or indigenous communities, and what are the risks? And have you had the same experience as us, or perhaps your experience has been different? Can I start with Professor Baker, please?
Thanks, and then that's a hugely important issue. I would say in New Zealand, because such a huge focus on ethnic inequalities and also our treaty relationship with the Indigenous Maori population, that all strategies have equity as a key driving force. And we knew that if there was widespread COVID-19 transmission in New Zealand, based on the pattern of previous pandemics and inequalities with other infectious diseases, that there'd be a very disproportionate effect on Maori and also Pacific migrants in New Zealand. In the end, we didn't see that because we didn't have enough transmission in New Zealand. We had 25 deaths, and we had, I think probably only about 1,200 actually introduced cases, and most or circulating cases in New Zealand, and the rest were cases detected at the border, which is still added to our total, of course. So we never saw ethnic inequalities manifest, just because the most pro-equity thing you can do is not have the virus in your population. And that policy was very strongly supported by by Maori and Pacific groups. And they were very, we worked very hard on looking at inequalities. In the end, the main problem is actually that the response has been harsher on low-income people. Unemployment has risen slightly, and housing problems have been exacerbated. So there are ethnic inequalities, but from the response more than from the disease.
Thank you. Professor Moore.
No, the vulnerability of Indigenous people, I think, is really demonstrated by the fact they are very high priority in terms of receiving the vaccine. So we certainly recognised that is a vulnerability. One of the elements we haven't touched on, of course, is luck. I think there has been an element of luck that we have not seen widespread disease within the Aboriginal and Torres Strait Islander community. I'm sure Catherine has broader, but everybody's touched on equity. Boy, if we ever needed to understand the social determinants of health, this was a very clear demonstrator of it. And for those of us, probably everybody here who's very familiar with Sir Michael Marmot's work, if people had been paying attention to that a bit earlier, I think we would have been also taking a much more targeted approach.
Just before we move to Professor Bennett, do you have the same problem that we have with much lower uptake on the vaccine within ethnic communities?
Let me start with Indigenous communities, because actually we have a very high compliance on all vaccines in our Indigenous communities. It's sort of the only area that's back the front for what we would normally expect. And I don't think we can lump all our ethnic communities together, because different ones have different approaches. And that was one of the things that Catherine mentioned earlier, was targeting those particular groups. And that was, I think, one of the keys to avoiding the outbreaks in those things, and making sure that their community leaders were engaged and understood.
Thank you. And Professor Bennett.
Yeah, look, just to add, in some ways, our Indigenous community in urban areas was a bit of a model in Victoria, because of their own networking and community supports really helped people who were in isolation. So people were holding up some of those as really good examples of ways we should think about supporting people in community. And with our contact tracing, I mean, that was one of the big shifts in my state. It was a centralised health system, was moving to community-based. And that was also, you know, very much a partnership with local community health services that already had established relationships with community leaders. And I think we've still got a long way to go down that path when you've been very centralised. But at the same time, that makes an enormous difference, both to the quality of information you actually get into the health department and the way you can work with community to manage those outbreaks and to learn about what's really happening in the community as well. So decentralising, community-based, and learning from some of those community support models.
Thank you. And did you want to add anything, Professor McKee?
Well, not really, except to say that, of course, there are quite important differences between the Aboriginal population in Australia and the Maori and Pacific Islanders in New Zealand, and particularly the treaty rights under the Treaty of Waitangi, and that does shape all sorts of things. But we have the experts here, so I just add that comment from afar.
Thank you. Back to you, Chair.
Thank you very much. Now, Baroness Masham.
How many vaccines have been administered, and what extent is the rollout of vaccines part of overall COVID strategy? And can you comment on the UK's approach to increasing the interval between vaccines? I have a personal interest in this, as I had the first Pfizer, and suddenly from 3 weeks it was changed to 3 months. So I haven't had my second. Could we have Professor Martin first, please?
Well, we looked at, in Independence Age, we looked at this issue of extending the interval of with the vaccine. In an ideal world, we wouldn't have to, of course, but we believe that if we take, say, a theoretical 100 people, it is, and you have 50 doses of, or if you have 100 doses of vaccine, it is better to give all 100 75, 80% protection rather than give 50% of them 85 or 90% protection and leave 50% of them unvaccinated. So we came to the reluctant conclusion that what the government in the UK is doing is actually the right thing to do here. But clearly we need to make sure that then the second dose does get administered without too much of a further delay.
Thank you.
What about New Zealand? Professor Baker.
Yes, well, there's very little vaccines being administered in New Zealand at this point. We've got some Pfizer vaccine that has been given to the border workers. It's quite interesting, the prioritization is very different in countries pursuing elimination, because you start with your border workers and then you work through healthcare workers and then start to work through the vulnerable populations. But that's going to take us till the end of the year, because the vaccine arrival is at much smaller levels, because it's not a matter of life or death in New Zealand, but the border workers have been a key priority and they're being vaccinated now.
And anybody else want to comment?
Actually, it's similar in Australia, but the Prime Minister and the Leader of the Opposition got theirs today. And but we've really only just received the vaccine. It's starting to roll out now, but a similar situation to New Zealand. We will have more of the AstraZeneca vaccine because it's going to be manufactured in Australia.
Thank you. I was just going to say they're planning, they're hoping for coverage in 9 months' time. That's the aim. I think we are going to our most vulnerable at the same time as we're going to our border workers in our first phase of our vaccination rollout in Australia. But how far down the vaccination pathway we need to be before we start to integrate other policy shifts, that's yet to be seen. So we will continue with our precautions in place until we're at least some way along that path.
Well, thank you very much indeed.
Indeed, thank you all. And to round us off, Lord Russell.
We're not going to go to Lady Finlay?
Oh, my goodness, I'm so sorry. I can't read my own writing today. Yes.
Thank you so much. I'll try and be very brief, and perhaps the answers could be brief too. But we are quite worried, I think, about the reopening of schools and universities. and the potential of mixing and so on. I just wondered from Australia and New Zealand how you have viewed the reopening of schools and universities as well. So possibly should we start again with Professor Bennett?
Thank you. So as I said, we had a big focus on schools. We did a study in New South Wales early on and found very low evidence of transmission amongst children. If we had cases in school-age children, they didn't find other cases in the schools, and they only found one instance of a child who appeared to have been an index case in their household. And that was actually a 17-year-old who passed it on to his father. So that actually gave us some confidence around particularly the lower classes in schools. And as I said, in Victoria, our own modelling based on our own Australian data showed a very low percentage of our cases were children. Of course, we were testing symptomatic people preferentially. Children were more likely to be asymptomatic. But the only places we had school outbreaks was where we had a lot of community transmission, and it followed the community transmission. It was, I think, the children taking the virus into the school rather than schools being a significant incubator or accelerator in that community spread. Our universities have kind of taken a very cautious path in Australia as well. They've, of course, we lost our international students, but we basically moved them completely online, and we only started to open up campuses this year, but we're all going in for blended learning, and so it'll be a different approach to education for some time yet. And the focus was really trying to get people back in essential classes like prac classes, but then thinking about density limits, wearing masks, and so on. So it's been a measured approach to try and make it a safe option to go back. But equally, we looked at preschool, young children, and the sort of primary school age here in Australia up to 11, and then our secondary school age as a separate group. And so we had staged return after lockdown that actually broke the school groups up into those different age levels, and then universities came late.
Thank you. Can I just ask very briefly whether the other two, New Zealand, whether you have anything to add to that? And then I do want to just take Martin for a quick comment.
Well, I think in New Zealand, we just had a 4-level system, and we treated schools, universities pretty much like other workplaces. And we regarded them as places where people met and the parents would meet. So generally they were in level 4, they were completely shut. That was our circuit breaker level, and level 3 largely shut.
Right. Martin, have you got a comment?
Yeah, look, we know that this is a virus that is transmitted in situations where people meet together indoors for prolonged periods of time, and it doesn't differentiate between schools, bars, restaurants, and anything else. There are certainly children are at lower risk, but as we're opening, as we're seeing the experience in Israel, children are becoming more affected as the society is opening up a bit. So we just need to be very cautious. We've put out a lot of detailed advice on making schools much safer, investing in ventilation and spacing and larger spaces for teaching and so on. And it's just unfortunate that not enough has been done.
Our schools are quite crowded places, though, often with really poor ventilation here. And there is a pressure to vaccinate teachers as well, whether they should actually be vaccinated to cut down that pool now that the kids are going back.
Yeah, so the guidance from the JCVI is very much based on vaccinating people to reduce the risk of serious illness and of death, which is essentially related to age and underlying health conditions. I think that's a good principle. There is evidence that the vaccine is reducing transmission, but I don't think that's enough to change it at this stage, personally, but I realise that there are differing views on this.
Yeah, thank you. Thank you, Leila.
No, thank you. And sorry I missed you. And now, finally, Lord Russell.
Yes, very quickly. So the question is a very brief one to each of you, which is if you had a single key message to give to the government here, what would it be? Could I start with Professor Moore, because the comments you made about the way in which the Commonwealth and the different states were working together is very prescient here, because we have had our problems with the UK government, which is actually comprised of 4 different national governments, not always agreeing with one another. So what advice would you give the UK government, Professor Moore?
Number one is health and economics are integrally connected. They are the same. They are the same thing. Decent health and the economy follows. It's and vice versa. So that's element one. Element two, and you touched on it, Lord Russell. It's coordination, because when you've got that coordination and agreement and compromise made, then people it increases trust. They weren't always in absolute agreement. And so the governments would then identify that we're going to do things slightly differently in Queensland because we haven't got the outbreaks that are happening in Victoria or whatever, and this is why we're doing it. And so it was still a coordinated effort, but allowing the exception, if you like. And so they were seen to be working together for the benefit of the community as a whole.
Thank you very much. Professor Bennett?
I think it's interesting that over time our governments have probably started to take quite different views in terms of, state border closures and so on. So I think actually to the government, it's about leadership. And I do think, we had strong leadership, we had the National Cabinet, but we could always have stronger leadership, when you're looking at having a national approach to your border control and the way you manage your quarantine. We have very strong national leadership here around the vaccination program. That's the first part of this whole effort, where they've actually brought together a forum where they've brought all the key scientists, the commentators, everybody together in the room. And we're just about to have our third forum. That it's really important to actually think about that, to actually think about having that coordinated approach, getting the best advice, putting your heads together about who should be vaccinated, who should be in each phase and so on. And also just bringing your communication strategy together. So national leadership really matters. It doesn't stifle what's happening at local level or across your different contributing leadership groups, but it's critical that you do have that consensus and coordination over the big issues.
Thank you. It clearly does help if your leadership is not selectively deaf, which ours appears to be. Professor Baker?
Well, I am a convert to the elimination approach. I think the evidence base is compelling, and I think it does provide a unifying goal which coordinates strategies and motivates people. And so I would say, give it a go.
Yeah. And lastly, Professor McKee.
I would ask the government to tell us what your objectives are and how you hope to achieve them. It's as simple as that. I'm still confused. There are far too many vagaries in the roadmap that we have.
I think the problem is they're confused too, Professor. Thank you very much.
And on that bombshell, yes, indeed. Thank you so much all for taking the time to be with us our morning, your evening, especially those who have stayed up well past bedtime. I hope that many people who are watching will take heed and take on the advice. And we're very, very grateful. I think this session has proved to provide a lot of clarity to the thinking that's going on in the UK. So I thank you all very, very much. Thank you to our parliamentarians. Thank you all for watching, and stay safe, everybody. That's all we can really say at this point, isn't it? Take care.